All right, everyone. The time everyone's been waiting for now, our keynote address. And some of you may have seen this is the Ira Hiscock Endowed Lecture Fund. And Dr. Hiscock was a leader at the Yale School of Public Health and moved to Hawaii in the 1950s and was instrumental in both starting the public health program here and eventually the School of Public Health. And when he left and retired, he created an endowment. So the Ira Hiscock Lecture has been going on for over 30 years now, and has included Ted Kennedy, numerous APHA president-elects, and various other people. So really, this is a very special lecture for us, and as is the tradition of the Hawaii Public Health Association, we're delighted to have the president-elect of the American Public Health Association this year. Dr. Mel Shipp, I think, is a little bit of a different public health person for a lot of us, as he is a dean of a school of optometry at the Ohio State University. And it's definitely an area that I think we don't think about a lot of times when we think about typical public health, is the need for public health in optometry and eye health. And Mel has really been a leader in the field. He's really done a lot of incredible work. He's pretty much sat on, as far as I can tell, every board at APHA. And has been really busy. He's also done so many things with the national level eye health. And he did mention to me that he saw my article on optometry and vision science on sunglass use in Hawaii, and it was very instrumental to his thoughts in the area. Not really. Did mention to me he likes golfing, and he brought his clubs here, so I think I'm going to help get him here. But we're really honored to have him. And Mel, if you can come up, and we're really welcome to have you here.
Well, first of all, I'd like to say thank you for that wonderful and generous introduction, Jay. I appreciate the opportunity to be here with you. And I'd be remiss if I didn't thank some other folks that were special in us getting here. We had a rather challenging time getting here from the mainland. And I'd like to pay a special thanks to Gerald Ota, our host. Gerald was extraordinary in terms of making arrangements for us to be here, and even thought enough to make sure that we had enough to eat, because we had not had a chance to eat since we'd gotten on the plane in Houston. Also like to thank Lisa Maddock for making arrangements for this presentation to be here on time. And before I do anything else, I'd like to congratulate all the wonderful people here. Your membership efforts and your association are remarkable. I think you went from a number of 30 up to 300 and some. That kind of increase, I think maybe you could tell me how you did that so I could take that back to the APHA. Also like to congratulate the practicum preceptors and students that were recognized tonight. And last but not least, congratulations to the new leaders of the Hawaiian Public Health Association. I understand from talking with Gerald that we have a rather diverse group of people in the audience tonight, and so I'm going to start off with some assumptions that perhaps we need to make sure that we're all in the same time frame or the same level of understanding with regard to public health, equity and scarcity. And so I'm going to talk about these perhaps on a very basic level, but also with enough depth that hopefully will be challenging to those of you who've been in public health for some time. So let's begin with something, one of my favorite models of public health. Basically, it's a rectangle that the top of the rectangle represents the optimal health for a given individual or organ system. The bottom of the rectangle is the obverse of that. That's the absence of health, death, or the lack of function for a particular organ system. Under the best of circumstances, and that rectangle goes from left to right in terms of time. So under the best of circumstances, in a perfect health condition, a person would be at the very top of that rectangle all along to the end of life. Nobody's escaped life alive, at least that I know. And finally, at the end, when you died, it would stop precipitously with no real compromise in health ever. We all know, however, that's not the case. The natural tendency is for us to be in that wonderful health status, but always there's something pulling us towards the negative part of that. The death, again, a loss of life and or a loss of an organ system or function. Fortunately, there's something that happens, or that typically happens, and that's the clinical horizon, something that happens in between there, where either the patient has symptoms and or a provider is able to detect signs that would indicate that there's a change, a physical change or some sort of change that's happening, that the health has been compromised. Once that's identified, there's a possibility of an intervention. that would allow one to regain full health, as in condition A, or a portion of health, as in B, or a rather compromised health condition with C, but you're still hanging in there, you're still alive. So those are the things that, again, happen as a result of a clinical intervention. In public health, we break these areas down so that we really get the definition of what public health is all about. It's all about prevention. Primary prevention, secondary prevention, tertiary prevention. In the primary portion, these are primarily health promotion, education, clinical care, and rehabilitative care in the latter part, and tertiary prevention. But as we'll see, or as you can see, there are costs associated with each one. In the case of primary prevention, it's relatively inexpensive. Clinical care and rehabilitative care are far more expensive, both economically and in terms of the cost for the person or the individual or the organ system. Public health is constantly trying to drive things back to the front of that particular rectangle so that the costs are low or the inconvenience or the discomfort to the patient is low. So that's, again, a very nice model. It captures all of what we do. I've heard discussions of people saying public health should be at the table when we talk about health reform, et cetera. The argument I would make is that public health is the table. And if you think about it, we are, as public health people, very, very diverse. We approach health from a variety of ways. We work together collaboratively to try to maintain optimal health for individuals, for communities, for our society. If we take that little piece and we talk about that in terms of an individual, that person's health stock, like in the stock market where you have the things that bounce around, and we follow a person from their birth on to the end of their life, there are lots of little blips that can occur along the way. There could be a perinatal situation that causes one not to be at optimal health, but one recovers from that and regains full health, moving on to some other acute condition that might happen during the course of life, appendicitis, an acute infection, from which there is a recovery, an auto crash in which perhaps there's some lingering loss of function, and then the more devastating conditions like cancer, where there's a gradual erosion of health over time, resulting in death. This is, again, a composite that may happen for a given individual, and we see these kinds of events that happen with time. I'll refer back to this chart again as we get farther into the discussion, but it, again, is a composite of the things that can happen. Each of these things, by the way, the perinatal situation, the acute infection, the auto crash, cancer, all of those things, in my mind, are things that public health people can do, ought to be concerned about in trying to maintain the best, the most optimal health condition. Something that will help us also, too, in this discussion is terminology, making sure we have the same definition. So I'm going to talk about community, I'm going to talk about health equity, health inequities, social determinants of health, health disparities, and scarcity. Again, the challenge of this topic that I have for this presentation. With respect to community, we're talking about a group of folks who have a shared identity. Basically, they live in the same area or geographic area. They have some level of interaction with each other, and they have a sense of belonging with their community. And typically, there's a common political or social responsibilities that are associated with that. We all have communities, and we all have various communities. There's a community right here in this room, but you also have communities in your home. When you go home, even the community of a family, the nuclear family would be another example. As a nation, we have a community. As the world, we have a global community. So all of these are various subsets of this notion of community. With respect to health equity, this is a goal. It's the ideal. It's the idea that everyone has the ability to have full health potential, that no one's disadvantaged and unable to do this because of their social position or other circumstances beyond their control socially. So that's what health equity is ultimately about. It's what we try to attain, but it's not always possible. In fact, the sad story is that more often than not, we have the challenge of health inequities, where there's a systematic and unjust distribution of social, economic, and environmental conditions that we need for health. We know that. We've talked about that here. I heard the presentation from your legislative committee. Indeed, their efforts are aimed towards trying to address some of these issues as well. They typically are related to the inability to obtain health care, access to quality education, housing, transportation, employment issues, especially now in our economy, are even more of a demand or a challenge there. And of course, the result of that is that we have, as the picture indicates, a variety of outcomes that are not pleasant for either for individuals or for our society. Social determinants of health go from the individual, the group, the community, and finally the political, social, economic environment that we live in. And those resources that we use, like food, supply, housing, economic and social relationships, etc., their distribution across populations affect our quality of life as individuals and as communities. This particular slide from CDC is indicative of this. It basically shows you have two potential plants that are in different environments. In the one case, you have a situation where there's a very supportive environment. That's the one to your right. The plant has a good root structure because it's based on all the basic requirements that one needs to be able to survive and do well. And the challenges that you see up in the leaves there are the same challenges that are experienced on the tree on the left, but those challenges are much more severe because the understructure, the infrastructure for the plant on the left is not as strong, not as robust, not as healthy as for the one on the right. So those social determinants where the inequities are high, you have a poor result. Where the inequities are low, you have a very good result or a good outcome. Health disparities is the crux of all of this. It's a difference in the incidence and prevalence of health conditions on the basis of one's social group or social situation. Clearly, the factors that are influential there are the age of individuals, their race, ethnicities, socioeconomic status, health orientation, gender, etc., that are listed there, and combinations thereof. So, this is our ultimate goal, to try to reduce the health disparities that exist within our communities, and we'll talk about how best to do that here in just a moment. There are some conventional best tips for better health. We'll go through those very quickly. If you don't smoke, that's a good thing. If you can stop, then please do. Have a balanced diet, eat plenty of fruits and vegetables, stay physically active. Manage your stress. If you drink, do so in moderation. Also, cover up in the sun, make sure you practice safer sex, get regular checkups, get screenings for cancer, be safe on the roadways, wear your safety belts, and learn the ABCs for resuscitation for those in distress. However, what your doctor didn't tell you are, don't be poor. If you can, stop. If you can't, try not to be poor for long. Live near good supermarkets and affordable fresh produce stores. Live in safe neighborhoods with parks and green spaces nearby. Work in a rewarding and respected job with good compensation, benefits, and control over your work. If you work, don't lose your job or get laid off. Take family vacations and all the benefits you're entitled to. Make sure you have wealthy parents. Don't live in damp, low-quality housing next to busy roads or near polluting factories. Be sure to own a car if you have to rely on neglected public transportation. And last but not least, learn how to fill in the complex housing benefit application forms before you become homeless and destitute. These are funny, but they're serious. I mean, these are the things that cause those health disparities that we talked about before. These are the social determinants that people don't have control over, and if it was a problem before, it's even a bigger problem now with the economic circumstance that we have. Place matters. If you live in communities of opportunities with all the things that are listed here, you will have good health status. If, on the other hand, you live in low-income communities with all the less than optimal circumstances, the likelihood is that you will have poor health status, and that will contribute to the health disparities that we talked about earlier. Going back to our model here again, if in fact you had a condition like diabetes, and I think some folks are recognized for their work in diabetes, you understand that diabetes, the symptomatology is relatively late, and if you don't identify to regular checkups, et cetera, early, some changes that can happen that are irreversible, even related to the work that I do with eyes. So if there is no clinical horizon, either there are no symptoms or the signs, or if there's not access to health care, that's not there, suddenly the options of improving one's health to the optimal status, or to some fraction thereof, or even to some low fraction goes away, and suddenly we have a situation where there is a death, there is a terminal, there's a loss. So clearly, this is not a circumstance that we'd like to find ourselves in, where people do not have access to care or do not have the appropriate factors that will help them maintain their health. That being the case, that's that composite that we talked about before, where there's an absence of these structures, these help structures. Suddenly we have a lower quality of life, and as you can see, an earlier death because of that. So these are the things that we're working against in terms of how we're trying to deal with the issue of health equity and try to remove the health inequities in a very composite or complete way of looking at things. The next part of the discussion I'd like to have with you today is about scarcity. Scarcity is actually an economic terminology, and those of you who are health economists will understand that scarcity kind of doesn't fit in a sense, but then again it does, and I'm going to try to make the force fit here anyway. But scarcity within an economic context refers to limited resources, not the lack of riches. So we'll talk about that a bit more. The next graphic is very helpful when we look at how, for example, countries look relative to health. And if we measure health in terms of length of life or life expectancy, which is one of the things that public health folks typically embrace as a reasonable measure of performance, we find Japan at the top of this list. And we find the US well below, down in 29th to 31st place on this list. Remarkably, however, if you look at the cost, the money that is spent to maintain or to attain these numbers, we spend almost 3 times as much. Is it 3 times? 3 times as much as Japan for a much, much poorer outcome. So clearly, it's not a matter of having wealth necessarily that, or ability to pay for services that provides longevity. Clearly, there's something else. This particular graph is a graph of, or a scatter plot of life expectancy with respect to gross income, life expectancy being in this direction, so higher is better, gross income being across the bottom here. Interestingly enough, you have the US, which has the highest income, gross income per person, but with respect to life expectancy is very low, among the lower ones. Japan, on the other hand, is about the middle of the pack, but it has the highest of all. So there's not a relationship, and there's kind of a cloud of points. You really don't see a linear relationship jumping out at you as you look at that particular slide. This particular slide is even more telling. Here again, you kind of have that same group. They're kind of a subset over here. But if you look across at where the US is, and you look all the way across, folks with about the same lifespan, you find Cuba, which has a national income per person that's much, much less. So it's not about money per se. It's how the money or how the resources are being distributed within the population that allows for these kind of life expectancies. This next slide, for those of you who are environmentalists, and I don't know if we have any, but it is telling to note that with respect to emissions, there's also a similar relationship. Here you have a place like Costa Rica that has a similar life expectancy, but has much less CO emissions. So clearly the environment is another part of this, a part of this solution for making sure that we have health equity or healthy environments. This slide is interesting in that we look again with gross national income across the bottom here, along with the index of health and social problems. Here we find the US having the highest problems and the highest income and a cloud of points. So basically there's no real relationship between money and the lack or having health and social problems in a community. One thing that is interesting, if you take those same countries now, and you look not so much at what the average income is, but rather the difference between the richest of the rich and the poorest of the poor, you find here a graphic that shows you that Japan, there's a lesser difference than there is, for example, in the US and the other countries on this end. Now we'll plot those numbers, and let's see what happens with respect to health outcomes. Here we have a very strong linear relation. The correlation is very high. Here we have Japan, which has low income inequity, but a much better health and social problem circumstance than the US, for example. And you do see a very strong linear relationship here. The next slide. We have a similar circumstance with low or income inequity being low on this end, high on that end. And the percent with mental illness, again, a linear relationship. There are some outliers here, but more or less there is a linear relationship, so that Japan, again, on the low end, with low income inequity and a much better circumstance with respect to mental health than the US on the far end. The question would be, well, and those of you who are academics, you should obviously question any data. Well, perhaps you have these differences because of culture, perhaps it's politics, perhaps it's governmental, there's something else that might explain this away. So if you now take that same analysis and you look now at the US, we have the same government, we have the same culture, we have the same, well, more or less everything, except those of you in Hawaii, you have a beautiful island, you're well away from everybody else. But indeed, we do share a lot in common relative to other countries. And I would note for you, let's see, Hawaii here, there's about a 3-year difference between the highest expectancy and the lowest life expectancy groups. And that's kind of at the lower end of the pack with respect to the states. And that's something to remember as we look at some of the data that is specific just for the US and not for countries in general. First of all, we found that there is only a weak relationship between the average income per person and better versus poor. It's kind of suggested that there's perhaps a linear relationship here, but it's kind of not a very high correlation. The next is a bit stronger indication that income inequity, when it's low, as is here, there's a better social income circumstance. So Utah is doing very well, thank you. At the far end, Mississippi, Louisiana are not doing so well. All right, so they have a higher income inequity and they have a worse circumstance with respect to social and health problems. Similarly, with respect to income inequity, low, high, and percentage of population dropping out of high school, we have, again, a more linear relationship as we have less of a difference with respect to equity. This particular slide is with respect to births and abortions. Again, the same relationship. It's not quite as strong, but there is a suggestion of a linear relationship here as well. With respect to homicides per million, again, we have a suggestion of a linear relationship here as well. Interesting, Hawaii is doing pretty well. Ohio, where I'm from, we're kind of, I don't know if you noticed it in the past several slides, we're kind of in the same bailiwick with respect to performance, which is a good thing. So I would hope at the end of this, we do find that the social determinants of health that we talk about and we sometimes pass off are extremely important at the front end of that prevention scenario. So access to healthcare is extremely important, access to the appropriate resources, food, housing, etc., education, employment, environment, all of these things are extremely important for the well-being and health of individuals and society. CDC has established on the basis of the prevalence of certain conditions that we should look at the challenges that we have that are foremost in our minds, that is eliminating racial and ethnic disparities of breast cancer, cervical cancer, addressing disparities in diabetes, and improving community health, and the solutions that they've addressed. And community comes up again and again and again. Community, we talked about earlier today, and I would ask of you, each of us has a community, that you embrace your community, make sure that you understand its challenges, its problems, and serve as a resource for them. Bringing this down to communities now. We're on your island. You know it far better than I do, but I asked a person who works with my wife. I didn't mention my wife before. My wife, Dr. Melvin Shipp, is a former assistant director of the Ohio Department of Health. And when I told her I was giving this presentation, she said, "Oh, you need something that's going to be relevant, that you can show." And so with her help, I was able to generate some of these graphs and charts. Probably you've already seen these, but at least I'll share them with you for what it's worth. This is your island. The next graphic basically shows your island with people. It's now color-coded with respect to SES. So the darker orangish colors, these communities, for example, are less affluent than the paler colored areas. And you can confirm with me whether that's true or not. All right. If you now do an overlay, that same layout with education, you'll find with respect to the hash marks that are like squares, isn't it interesting how you have the same situation? You have lower educational attainment or achievement in the same areas where you have this lower SES. So here is a population, here's a community that is challenged more severely than other populations because they, number one, lack the financial resources, and they also lack the ability to generate income to make up that income. The education is not highly attained, so the net result is these are folks who are going to have a hard time helping themselves. But I would, again, applaud you, because when you take a look at the statistics that I mentioned before, with respect to the differences of lifespan, you're at the to the lower end of the pack. The differences are much, much less. But let's take a look at this one community here that kind of stands out, and it's Census Tract 15003009-701. You may know where that is, I don't, but I do plan to check it out while I'm here, just out of curiosity, just to see what that community looks like. And again, this particular community is going to be a bit more challenged than most. It is perhaps unique, perhaps not, with respect to the island. I would think that it is, in terms of its demographics, with respect to race, and also with respect to age, and with respect to those who are at or above the poverty level. So here's, again, a tool that was readily available in Ohio, and I know that you have access to or could do the same thing here if you have not already. Let me now take a little commercial. I'm here courtesy of the American Public Health Association. I'm deeply honored to have been elected President-elect, and my goal this year going forward is to try to do all that I can to try to connect with the affiliate groups that I'm able to meet with. I'm delighted to be here with you today. I would hope to have a very robust discussion with you, either during the question and answer session here or in the reception following. I want to know your issues, especially with respect to what the APHA can do, the national organization can do for you as a state affiliate. APHA has been around for a long time, 140 years. And you'll notice the key functions, and it's pretty parallel with what was mentioned here today. It's about advocacy, policy advocacy. That's where it happens. At the national level, we have policies, and I'll talk a bit about those more later, that might be of even assistance to you as you now go to your state legislature to talk about things that you need to have done here to help you do the things you need to do to improve communities' health. And again, improving communities' health through education and health services is something the APHA has been about since its founding, and that's ongoing today. With respect to policies and practice, it's all about those emphasizing the primary prevention aspects: clean air, clean water, nutritious food, healthy lifestyles, et cetera, et cetera, et cetera. All the things that we know that are less costly in terms of economics and less costly on individuals in terms of health costs. Our strategic map is pretty much self-focused right now. We're trying to get our act together, but importantly, this particular let's try that again. This box right here is one that we really emphasize, and that is getting out, number one, for the things that APHA National thinks is important, but also trying to embrace and include things that relate to the affiliates as well. Our composition is primarily academicians, and I'd like to see that change, and I think that those of us serving on the executive board feel the same way. We want more engagement from people who are boots to the ground, who are doing the work. And so we're going to be looking for ways in which we can connect with and involve affiliates more at the national level in our structure. The organization is in Washington, D.C. We have 53 state affiliates. That's because the state of California is somewhat schizophrenic, and they have a northern and southern California portion. And New York and Washington, D.C. are standalone with respect to their affiliate organizations. And that's okay. The more the merrier, quite frankly. There are 27 sections, and I have to apologize for those in the social work. I did not list it on this group. Looking at this particular list, it's important to note, went back to that model I mentioned earlier on with the public health model, that we have all those sections mentioned. And let's see if I can find my crib sheet to talk about that. In primary prevention aspects, we have, here we go, alcohol, health education, social work, food nutrition, and environment. Those are the things, again, the precursors that can allow for or mitigate against having health conditions. In the secondary prevention aspect, we have obviously the clinical areas of chiropractic, health services, medicine, nursing, oral health, podiatry, vision. And in the tertiary portion, we have aging and disability as two very specific sections that relate to that. So again, public health is the table. All these disciplines, entities are together at one time talking about these common issues and finding ways in which we can work together collaboratively to make a difference. Another area that we are emphasizing, and that's because of the economy now and the fact that the uninsured is not going away as we might have hoped. It's more of a problem than it's ever been, and there are more and more people who are at risk because of the economy. But back to the issue of policy statements. I talked to you about health equity today. There are a number of specific policies that have been vetted through the policymaking process at APHA. These policies are online. They're available not just to APHA members, they're available to anyone. So those of you who are working with legislative areas, if there's a particular area you're working in, just go to that website, type in the term, and you'll find a policy statement that has been vetted, has references, and might be useful to you in making an argument. So here's one that relates to health reform. There are others that relate to transportation and land use. There's still others that relate to health infrastructure, the state and local health departments, and still another with transportation injury control. Equity with respect to immigration policies is yet another. There are also a series of policy statements that relate to scarcity. For example, with eye care, vision disorders, the fact that that is not as accessible as it could and should be. Scarcity relative to international health and those kind of issues that go more globally. Here's yet another one that relates to international health, but more specifically about war and conflict and its impact on individuals. The last one I typed in was health disparities, and there were so many that there are 36, 37, that are there and available, again, that are referenceable or that you can use in making an argument as, again, you go to the legislature. So this is what we are about at APHA at the national level. And again, my hope, my goal, my expectation is that we will connect very strongly with affiliate groups like yours. I applaud you for all the wonderful work you're doing, and I wish you the very best of success as you continue to do that. In summary, we've talked a bit today about public health. It's more than just health care. One of the things that distresses me is the Affordable Care Act, and they talk about health care reform. The word care keeps entering over and over again. The notion of waiting until something's broken to fix it is not what we should be about. We know what the precursors are. We should identify them early. We should do all that we can to educate and mitigate against these factors so that people do not become ill, do not become sick. That's not to say that we don't need health care. Obviously we do. But we shouldn't put our emphasis there. It's gotten us in big trouble. The graphs with respect to life expectancy shows that very clearly. We spend an awful lot of money on health care. The result is that we still do not have the life expectancy we should have as the country that we are. Scarcity is not just about how much money you have. It's how you spend it. It's just like at home, folks. You know, if you don't spend your money well, you don't get a good outcome. We're having that problem in our country now. I would hope that over the course of the next period of time that we'll get smart about that, and our decision makers will do something about that as well. Last but not least, I'd say again, know your community, embrace your community. I applaud you as a state. You have done that exceptionally well. The numbers reflect that. And obviously from what you're doing, you plan to do even more of that. So thank you again for the honor of being here with you today. I appreciate this opportunity. I look forward to your questions if you have any at this time. And for your hospitality, I say mahalo.